Okay, good morning. Good morning again, everyone. Today we're going to discuss some overview and some information about epilepsy and the pharmacology and treatment and strategies for the treatment of epilepsy in veterinary patient populations. So we'll be going over some information both about epilepsy, defining some terms like we normally do, just so we're sure that we're talking about or thinking about similar things when these terms come up. And then tomorrow we'll do the same thing for anesthetics and pre-anesthetics, and that'll conclude the neuropharmacology portion of the course for this fall. So today, as I said, we're going to talk about anti-seizure medications or anticonvulsants, and these are normally used in the context of treating the disease state of epilepsy. And so there's some terms, as I was saying, that come up commonly that I want to go over briefly just to make sure that we've got the same idea or the same thoughts in mind when we see these terms and use them in the context of the discussion of how the drugs are working that are used to treat these conditions. So a seizure or an ictal event, an ictus, essentially is just the consequences of an inappropriate level of activity in the nervous system, typically in the brain. So some inappropriate repetitive bursting, firing, typically of a cluster of neurons, at least initially, somewhere in the brain that's going to trigger a seizure episode eventually when it spreads from that foci or that source of this inappropriate activity. And so this is often, as you would expect, going to be associated with some sort of excessive excitability of these neurons. That's going to involve some depolarization of these neurons in some inappropriate manner that results in them firing high frequency, typically patterns of bursting behavior somewhere in the nervous system. And if that isn't controlled, then that can spread and lead to a seizure-like event. So a seizure is the consequence of this inappropriate neuronal activity somewhere in the brain. So a convulsion then is a related term, and we tend to use in terms of categorizing classes of drugs as anticonvulsants, anti-seizure medication, anti-epileptic medication. All those terms tend to get used somewhat interchangeably, but a convulsion essentially is just the typical observable or outward signs, the consequences of the seizure that you can observe in the individual that's suffering from a seizure, and this is often going to involve some inappropriate or uncontrolled muscle activity. So that's what actually leads to the outward signs, typically, that an individual is experiencing some kind of seizure. So these terms are all related, but they don't necessarily mean exactly the same thing, but sometimes they can be interchangeable, and sometimes if you're talking specifics in the context of epilepsy and its pathology, they mean slightly different things. Okay, so seizures and convulsions are related, of course, and the medications then that we use to treat these events are going to be classified as either anticonvulsants, anti-seizure medications, anti-epileptics. So as far as the types of seizures, over the years there's been an evolution and an ongoing discussion essentially of how to categorize or classify different kinds of seizure events. And so depending on the source that you look at, then you'll see different descriptions of things, but I'm going to just talk about what I think are the basic distinctions, generalized types. And in the treatment of epilepsy in humans, this is often very important because it can lead to some choices in terms of what the first line agents are that you might typically treat a human with in anti-epileptic pharmacology. But in terms of the veterinary treatment of epilepsy, there's not such as great a distinction. We tend to follow the same kind of strategy regardless. But in any case, just so you're aware of the different distinctions of types of seizures and how these are typically described and categorized, we have a case of partial or focal seizures. So as I've described, a seizure event as some inappropriate activity in the brain, then you would expect if there was some activity that begins at a certain site in the brain, and if that excessive depolarizing activity or bursting behavior doesn't spread beyond that location, that foci, that source of the seizure in the brain, then the consequences of that seizure are going to remain fairly localized then to that particular area. And so this is going to vary depending on the brain area that's being affected then, and we'll talk a little bit more about that. But essentially, in this case of a partial or a focal seizure, then this can lead to a wide variety of different types of convulsions or not convulsions, very simple things, for example, that we'll talk about that involve a very specific region of the brain that's having this inappropriate excessive excitability or neuronal activity. So in the simplest case then, consciousness is retained. The individual does not lose consciousness, and so it's not the classic type of seizure that many of us that are not familiar with the disease of epilepsy often think about. And that's leads to more of a scenario where we've got complex cases of partial or focal seizures where there's a spreading essentially indirectly to associated brain regions that can lead to the loss of consciousness. And so in veterinary populations, patient populations, then this kind of distinction often isn't available to you because this might require an EEG or imaging data that's done in humans, and so a lot of this terminology comes out of what we know from human pathology that may or may not be available to you in the veterinary case. But the main distinction here is to just realize or appreciate this idea that there can be fairly specific sites of inappropriate activity in the brain where these seizures are occurring, and that leads to a very particular type of seizure event. So one way to think about how this might be manifest or how you might actually observe the consequences of this is just to think about, for example, the motor and the sensory cortical regions of the brain. In this case, this is a human, of course, brain, this homunculus it's referred to as. And the idea of this diagram is that it gives you some sense of how much of this cortical neuronal computing power, essentially these neurons, how much of the brain is devoted to each of these regions of the body. So for example, it doesn't take a whole lot of neuronal control to maintain posture and large muscle groups in areas of the body that don't have a lot of flexibility or fine motor control is not required. Then you're not going to devote a lot of your motor cortex to controlling that area, in particular the body, whereas other areas of the body that have a lot more fine motor control, like your hands, fingers, et cetera, and extremities, are going to have more neuronal processing power essentially devoted to controlling and sensing what's going on in those regions. So the idea of this diagram is just to say that if you were to have, due to whatever reason, an inappropriate level of activity in the somatic sensory cortex, for example, let's say that's controlling some muscles in the eye and the eyelid, for example, you could have a seizure event that's going on in this sensory cortex that might trigger some muscle movements, or you might have a seizure event in the motor cortex that's controlling those muscles in the eyelids of the eye, and you could have a fluttering of an eyelid or something in the individual, and that might be the outward sign or the convulsion event essentially that is indicating that there's a focal, localized seizure event going on in that particular part of the brain. So it could be something very innocuous, very mild. It doesn't have to be a very dramatic type of outward sign or consequence that might be indicating that there's some sort of seizure event going on in a particular part of the brain. You might sense some sort of burning or itching sensation in the skin of the back of your hand or something, for example, and that might not be due to an appropriate peripheral sensory activation or input, but it might be what's going on at the level of the sensory cortex or the motor cortex, for example. So this just gives you some idea of how, depending on what region specifically of the brain is the site or the foci of the inappropriate activity that's going on in that individual, that can lead to a wide variety of different manifestations or outward signs of what's going on during that seizure event in the individual. So in contrast then to these simple or focal types of seizures, partial seizures, there are the generalized seizures, and this is the type that maybe is what initially comes to mind when you think of a seizure event, a convulsive event in an individual that's suffering from epilepsy. The hallmark of the criteria essentially for a generalized seizure event is the consciousness is lost fairly rapidly. It involves the whole brain bilaterally, and so there is general widespread consequences typically of a generalized seizure event. So in tonic-clonic seizures or grand mal seizures, these are also typically characterized by a loss of muscle control, and so there's usually some periods of alternating between muscle rigidity and contraction, relaxation, tonic-clonic types of movements, resulting in jerking of muscle groups around the limbs, and so this is probably the more classic kind of more impactful image that a lot of us have that aren't familiar with epilepsy and various seizure states. There's another type of generalized seizure that's particularly notable in humans and is harder to characterize or identify in veterinary patient populations, in animals, in dogs and cats, for example. But these are the absence seizures or the petit mal seizures. These are characterized by a loss of awareness, so a loss of consciousness. So it's a generalized type of seizure, but typically with these seizures, body tone is retained, so postural tone is maintained, so the individual, if they suffer from this type of seizure, will stay in their chair, for example, at their desk. If they're a younger person in grade school, for example, they might be initially at least characterized as being a daydreamer. They're staring out the window, not paying attention, not responsive for periods of tens of seconds or more. And so this absence seizure event then is actually a epileptic type of episode in these individuals of a different type that doesn't involve the loss of motor control. So in humans then, this can lead to different drug treatments then that are initially attempted for these different types of seizures that have been found to be more effective. Certain drugs are more effective for absence classes of seizures than they are for the tonic-clonic seizures. Okay, so that's a really brief overview of just general types of classifications of seizures, and as I said, there's a lot more you could dig into if it's an area of interest and find finer degrees of classification of seizure events, for example, but that's going to be as far as we're going to go at this point in terms of just an initial overview of what you're likely to run into. Okay, so that's kind of the background for seizure events and convulsions and what we mean when we say those things. So then we have this disease state of epilepsy that's commonly the topic then of the use of anticonvulsant drugs in pharmacotherapy. So typically epilepsy then can simply just be defined as recurring episodes of seizures. So if you suffer from a seizure due to an identifiable cause, if there's a physical trauma, you hit your head, you're in a car accident, something happens and you have a seizure, that in and of itself does not mean that that individual has epilepsy. There needs to be a pattern or a history of ongoing seizure events that typically over time tend to start escalating at some point and of an increasing frequency and intensity before the individual is characterized as having epilepsy. So this is a fairly common, relatively common neurological disorder in the human population, occurring with somewhere around, depending on the source again, the data that you look at, around 1%. And there are a number of different causes for epilepsy, some of which have been identified and others not. So there can be genetic, inheritable types of predispositions to epilepsy and seizure disorders. There can be exposure to environmental chemicals, trauma, as I was saying, physical, obvious, known causes of damage to the nervous system that might likely be the underlying cause of the development of the seizures. So there's a number of different ways that an individual might potentially be subject to acquiring or exhibiting the disease state of epilepsy. So depending on the source then, in cats and in particular in dogs, certain breeds of dogs are more susceptible. It's not tremendously more susceptible, but again, depending on the data, the statistics you look at, the incidence of epilepsy or recurring seizure episodes in collies and retrievers and shepherd breeds of dogs is probably 2 or 3 times greater in some cases than the general population as a whole. So there's some predisposition, some genetic inheritable predisposition to epilepsy in certain breeds of dogs, for example, but it doesn't explain everything. So there's a lot of idiopathic or unknown origin, essentially, of the disease. And then finally, in the context of just discussing epilepsy, which is a chronic, as we're discussing it, a chronic disease of recurring episodes of seizures of a certain frequency, the condition of status epilepticus, which is essentially repeated ongoing seizures of longer events typically, is an acute medical emergency that needs to be treated. These seizures tend to be much longer, lasting several minutes in duration, and several instances or episodes occurring within a 24-hour period. So this can be a life-threatening event in the individual, and regardless of the cause, whether it's genetic or due to some trauma experienced by the animal, this needs to be treated immediately, as rapidly, as soon as possible. So we'll talk about what you might use in the case of status to break the cycle, essentially, of this inappropriate seizure activity that's going on in this individual. Okay, so as I've been talking about it, then you can imagine now that there's going to be a wide variety of different types of outward signs that an individual might be experiencing a seizure event. And so somatosensory events of the type that I've talked about go well beyond just the idea of loss of muscle tone and control and tonic-clonic type jerking motions of muscle groups, and can involve things like sensations, tingling, numbness. In the animals, of course, we can't talk to them, ask them about what they're experiencing, but animals can end up engaging in stereotypic behavior, repeated motions, as if they're trying to lick something, bite something, for example, exhibit other behavioral outward signs that are indicative of some sort of seizure event that might be going on in that individual. So all of the sensory inputs then in the sensory cortex, for example, that you can imagine are potentially liable and could be the consequence, essentially, the seizure event. So you could get essentially inappropriate visual sensations, seeing things, either real and real in terms of what you think you're seeing, or imaginary in terms of just hallucinatory type of events. But regardless, just inappropriate visual sensations, auditory sensations, olfactory sensations, according to what part of the brain is potentially being engaged by this inappropriate, excessive excitability that's going on. So all of these things then, as I was saying, a wide variety of different sensations potentially are experienced by the individual that is undergoing a seizure type of event. So of course, in the case of the typical companion animals and veterinary patients, animals may become aggressive during this type of experience. Of course, they don't understand what's happening, and so we'll talk about this a little bit more, but obviously this is typically a very anxiety-provoking episode depending on the particular type of seizure that the animal is experiencing. Okay, so as far as the pharmacology that you're now familiar with, what kind of strategies could we employ potentially from just a mechanism of action kind of perspective in approaching the inappropriate seizure activity or excitability in the brain, for example? Then we know that one strategy that might be effective to quiet or calm down the brain might be to interrupt or interfere with voltage-gated sodium channel activity in the brain. So you know already, we've talked about how voltage-gated sodium channels are required for action potential propagation, for example, communication between neurons. If the mechanism for maintaining a seizure and potentially spreading that seizure to other brain regions has to do with neurons in one area talking to neurons in another area and exciting them and having some sort of positive chain reaction type of mechanism going on, then if we were to administer a drug that could interrupt some of that excessive excitability, then that might be an effective strategy in terms of the treatment of epilepsy. So there's a bit of a fine line to walk with this strategy that and the others that we're going to talk about in terms of when you think about it, what you're trying to do is interrupt a pathological excessive amount of neuronal activity in the brain, but you don't want to simply sedate or anesthetize the individual so they have no quality of life. So if you're able to interrupt the seizure activity and stop the seizure events and prevent them from occurring again, but in the meantime, in between those seizure events, the individual is just sedated and sitting in a corner, then that's not much quality of life. So there's a balance that has to go on with these strategies, and we need to be able to try and provide something that's effective in terms of interrupting the pathology without unduly affecting the quality of life that the individual is experiencing. So we'll talk a little bit more about just these strategies and which ones make sense and why they might be the type of drug that you would try as a first choice and maybe reserve some other things for a later choice if necessary. But in general, if you can inhibit sodium channels, you would expect to quiet the brain. So similarly, you also know that voltage-gated calcium channels are involved in excitability and things like neurotransmitter release. So if we inhibit that kind of excitatory activity, then that's going to be potentially a beneficial strategy. Of course, as you probably already surmised or would guess, if you boost the inhibitory influence in terms of neurotransmission in the brain, if you turn up the GABAergic influence, then that's likely going to quiet things down in terms of inappropriate bursting type activity. So GABA compounds are a major class of anti-epileptic drugs that we'll discuss here. And then finally also potentially the converse of the opposite. If you inhibit the primary excitatory neurotransmission pathway in the brain, the glutamate system, then you'd expect to also be able to interrupt this kind of activity. So nothing too surprising, I would think, at this point in terms of just the strategy of how these drugs are going to work, why they might potentially be effective in turning down or slowing down or inhibiting excessive excitability in the brain. And an important principle to keep in mind then is when you try one of these drugs, as we talk about, and you get some effect, but maybe it's not as effective as you would like, the clinical efficacy isn't quite as good as you would hope for, and you want to add on a second agent, then it would make a lot of sense to choose a second drug that's using a different mechanism of action in terms of these general strategies to try and get some sort of synergistic type of effect by using a drug that has an entirely different type of mechanism of action. So it wouldn't make sense if you were using a drug that we'll talk about in a moment that's enhancing GABA activity to then add a second drug on top of it if that wasn't giving an adequate outcome, to add a second drug that also interacts with the GABA system. That might not make as much sense as choosing something that maybe was a channel blocker, for example. So just keep that in mind. Okay, so as far as the major classes of drugs and then specific drugs that we're going to pay attention to for our purposes, the barbiturates, phenobarbital in particular, is a barbiturate that has a relatively long half-life, and it's a very old class of drugs now, the barbiturates. A lot is known about them. The client, of course, the owner is in control of the drug administration in the patient, typically in the animal that's receiving these drugs, so you don't have to worry about overdose typically, other than the accidental variety or type of circumstance. So phenobarbital is typically going to be a first choice for maintaining animals that suffer from epilepsy in the treatment of that disease state. So there's a good a balance of clinical efficacy, a relatively low toxicity for a chronic, you're going to maintain this individual potentially for the rest of their life on these drugs that are used as anti-epileptic, anti-seizure medications. So you have safety, toxicity, side effects to consider, the cost that's going to, again, be a chronic ongoing situation, and then the efficacy that you get. So typically there's going to be some initial loss of coordination, some sedation, but some of that there will be tolerance that develops to those side effects. So after a period of a few days, typically the individual improves in terms of there'll be less sedation, less loss of motor control. So those things often improve. So in terms of the mechanism of action, you're already familiar with this. We've talked about it before previously. So barbiturate drugs enhance GABA activity at the GABA A receptor, that chloride channel complex, by increasing the duration of time that the channel spends in the open conformation. So more chloride comes across the membrane, and that anion, that inhibitory influence on the membrane potential then is going to tend to quiet down those neurons and interrupt the seizure events. So pentobarbital is a different barbiturate that acts in exactly the same way. It just has different pharmacokinetics. It has a shorter half-life than phenobarbital, and it can be a secondary choice, as we'll talk about in a couple minutes, for that acute medical emergency, that treatment or condition of status epilepticus, where you want to rapidly interrupt the seizure events that are going on and just get the individual stabilized and get them out of that potentially life-threatening situation. So barbiturates can be used effectively in that context as well, for just acutely interrupting a seizure event of ongoing nature. So phenobarbital, pentobarbital are a couple of drugs that act on the GABA A complex. As I've already mentioned, we've looked at this before. You know that the chloride channel receptor complex has got binding sites for benzodiazepines that we're going to talk about in a moment. So there are modulatory sites that can influence or turn up the activity, essentially, of these GABA A receptor complexes. So GABA, two molecules of GABA, just like nicotinic receptors with acetylcholine and nicotinic receptors, two molecules of the neurotransmitter bind, open up the receptor complex, and chloride comes into the neuron, and that tends to have an inhibitory, stabilizing effect on that cell that's being influenced by either a barbiturate drug or a benzodiazepine type of modulatory agonist. So as far as the use of benzodiazepines then and their effectiveness at enhancing GABA A receptor activity, diazepam or Valium is one of the first choices for that acute medical situation of status epilepticus. It's rapidly distributed and crosses the blood-brain barrier, and so it does a good job typically of rapidly interrupting that seizure activity that's going on in that individual. So it's often administered rectally in a suppository form just for practical reasons. If you've got an individual, an animal seizing, you don't want to be trying to get anything in their mouth typically, and even injections can be a little bit more problematic in that individual. So they're commonly administered through a rectal route of administration. Lorazepam or Ativan is another benzodiazepine option. So in general, if you have any of these drugs available, barbiturates or benzodiazepines, whatever you've got available, if you don't have a choice of whatever the typical textbook first choice is, all of them work in the manner that you would expect and will be effective in improving the likelihood that the individual will survive the status event if they're administered quickly enough. So all of these drugs, these GABA-A facilitating drugs, essentially are potentially useful for the treatment of status epilepticus. So you might think then, since we've often in the past characterized or compared benzodiazepines with barbiturates, what are the advantages, disadvantages? Benzodiazepines often are noted as having the advantage of having less toxicity, fewer side effects than barbiturates, so you would think that benzodiazepines would always be the better choice then in that context, but that doesn't turn out to be the case. And so, for example, in the context of the treatment of epilepsy, then it turns out, of course, since this is a chronic disease state, that you've got to continue to administer the drug to the individual in order to maintain seizure control. In the case of benzodiazepines, there is a much greater susceptibility to tolerance in the patient population. So a drug like clonazepam, that it can be used and is used as a choice for the treatment of maintenance of anti-epileptic uses, is effective, and certainly typically is effective initially, but over a period of weeks and months, the occurrence of tolerance becomes problematic. And so even though you maintain and are compliant, you give the right dose at the right frequency, then the drug tends to become less effective with time, and you lose adequate control of seizure occurrence and frequency. And so it's just a consequence of ongoing chronic administration of benzodiazepines that tolerance is a limiting factor in many cases. So that tends to then to take us back to the barbiturates in terms of first choices in the treatment of epilepsy for low cost, relatively low toxicity, and relatively good quality of life when dosed appropriately. So again, the mechanism of action that you're already familiar with benzodiazepines is the GABA-A receptor, tends to increase the frequency of opening of those ion channels. In the presence of a benzodiazepine, GABA is more effective. Okay, so what can we use then if these typical first choices don't pan out, don't give us the clinical outcomes that we're looking for, that we're desiring? It turns out that bromide salts, bromine, another anion drug like chlorine, can quiet the nervous system essentially. And so it turns out that these bromide salts, potassium or sodium bromide, can be very effective alternative choices, particularly in canine patient populations. So in dogs, bromide salts are often a second choice after phenobarbital for the maintenance and the treatment of epilepsy in those animals. So there's some practical disadvantages, one of which is the half-life of the effects of these bromide salts is very long, and very long in this case means weeks. So that leads to many weeks and even a few months before you can get the individual stabilized in terms of reaching a steady state level in the patient. So it can be a little bit problematic from a practical perspective and just getting the dosing levels correct in an individual as far as fine-tuning in any particular patient what their dose should be. So the mechanism of action, like I said, as far as we know, is essentially just turning up the inhibitory type of influence of membrane excitability with increasing those anions in the extracellular space in the brain, and some of those bromine anions are going to be getting through chloride channels and increasingly hyperpolarizing the cells and quieting the nervous system. So there is a noteworthy difference between, in this case, dogs and cats. Cats are do not tolerate bromide salts very well due to some respiratory problems that tend to develop. So they're not recommended as a typical first or second choice in the treatment of epilepsy in that patient population in cats. So for dogs, these bromide salts are relatively low cost, relatively effective, maybe even as effective as barbiturates, but there's just the practical limitation that I mentioned of being a little bit difficult to work with in terms of the half-life and getting the maintenance dose figured out for those individuals. Okay, so that covers the inhibitory side of things, the GABAergic type of signaling in the brain. And so as you would expect, anything you can do to turn up inhibitory control of what's happening in the brain is likely going to have a calming effect on the brain in general, and is going to be an anti-seizure type of mechanism or influence on neuronal activity. So what about other potential targets that we mentioned that would make sense if you somehow could turn down some of the excessive excitability that's going on during seizures? We've talked about NMDA receptors before as being one type of glutamate receptor that's present in the brain, and it's an interesting drug target in the sense that there's a lot going on at these glutamate receptors, this particular type, these NMDA receptors. There's a number of different drugs. We've talked about some antagonists, drugs like MK801 or ketamine, for example, or PCP that block these receptors and have some interesting effects. But in this case, there is an antagonist known as felbamate that has been developed as an anti-epileptic compound that has some, although not much use in human patient populations, but it can be typically used as an adjunct strategy, an add-on agent to something like phenobarbital. So this would be an example where we're taking a drug that has a different type of mechanism of action from the GABA system and adding it on to try to increase the effectiveness of the pharmacotherapy that's being used. So of course you could use this drug alone potentially, but typically for the most part it's not the first choice. It's for the most part used as an add-on type of agent in the treatment of epilepsy. And its mechanism of action then, as indicated, is essentially just an antagonist of this type of glutamate receptor. These receptors tend to fire during depolarizations and bursting activity. So if you inhibit that excessive glutamate, that extra glutamate activity that's going on in the brain during bursting behavior, then you might be able to interrupt what's going on with seizure events without blocking just the normal kind of bread and butter everyday glutamate transmission that's mediated by AMPA receptors, for example, that just allow neurons to communicate with one another. So the fact that there's this separate class of glutamate receptors that are only active at certain times provides a pharmacology mechanism of action opportunity essentially to target those receptors, block their activity without just shutting down the brain in general. So it makes sense that this might be an effective approach. So in addition to the glutamate antagonist strategy then, we've also got drugs that have been developed that are voltage-gated channel blockers. They tend to hit both sodium and calcium channels to varying degrees. So our examples of these kind of channel blocking, voltage-gated channel blocking drugs are levetiracetam and zonisamide, are either available potentially as adjunctive to add on to a drug like phenobarbital, or possibly if phenobarbital wasn't being tolerated well by a given individual, they could be tried as alternative therapies. So the mechanism of action for these types of channel blockers is, of course, they don't completely shut down all sodium channel activity or all calcium channel activity, because if that were to occur, then the individual would essentially be anesthetized and non-responsive. So again, we're thinking about trying to balance quality of life, trying to interrupt excessive activity and seizure events without shutting the individual down completely in terms of their nervous system activity. So there's always going to be that tension there, that balance between what is enough inhibition versus too much as far as balancing with those side effects. So the mechanism of action then, these drugs tend to inhibit repetitive firing activity in the brain due to shutting down these voltage-gated channels, maybe increasing the recovery time before the channel can open again, and that would tend to not block the first action potential, for example, but might prevent a burst of action potentials from occurring. So these drugs tend to slow down repetitive firing activity in the brain that's contributing to seizure activity. So of course, in the case of the treatment of epilepsy, compliance is especially critical because this is a chronic, ongoing disease state. So this isn't an issue that typically can be just treated for a short period of time and then discontinued, the drug therapy. So if the individual is diagnosed due to the severity and frequency of their seizures as suffering from epilepsy, then that's going to be from that point, lifelong issue then that individual needs to be treated for. And so compliance, of course, being regular and consistent with the application of these drugs, administration of these drugs is critical. That being said, if there's any change in the drug regimen, if you're going to try something that has a different side effect profile, a different mechanism of action, then of course it's important to taper off the dose of one drug as the other drug is being initiated, if you're talking about different drug classes, mechanisms of action, for example, because you don't want to abruptly discontinue one drug that's on board. That could lead to rebound seizures or increasing the likelihood of the frequency and severity of those seizure events in that individual. So using essentially good pharmacology, common sense in terms of tapering the dose, ramping up the dose of the second agent when you're trying to switch over is often something to keep in mind and try to manage. So the drugs that I've just talked about then are some of the most common that are going to be used in the veterinary patient population. As you can imagine, epilepsy is one of the more common human neurological disorders, and so there has been a huge amount of effort and expense over the past few decades developing anti-epileptic compounds, potentially for the treatment of the human patient population, and that's because historically, over the last few decades, it turns out that approximately, a rule of thumb is approximately 50% or so of the epilepsy patient population is well managed with the use of pharmacology and therapeutic approaches. About 25% get substantial but not complete relief using drug therapy, and leaving approximately 20-25% or so that essentially are refractory, that don't respond to drug therapy, and their epilepsy, their seizure incidence is severely impacting their life. So again, sort of historically over the years then, those individuals didn't have other options in terms of drug therapy. So you might know that there are strategies, surgery, for example. You can resect, you can identify in the human patient population the foci that's the source of the seizure episode that's affecting the individual, and attempt to surgically resect or remove that area of the brain. And of course, there's a lot of thought and attention paid to exactly where is the area, how is that going to impact the individual, what will the consequences be of undergoing that kind of surgery. But having a surgical approach is effective in many of those cases in individuals that otherwise have no quality of life due to the severity and frequency of their seizure events. So that's potentially available in the treatment of veterinary patient populations, but isn't as common as you can imagine, just due to practical issues of expense and access to that kind of capability. Another possibility that you're probably all aware of is trying to use dietary influences to interact with the disease state of epilepsy. So you may or may not be aware of a ketogenic diet, for example, strategy that seems to be effective in certain individuals, particularly younger individuals that suffer from certain types of epilepsy in the human patient population. And in fact, there is a special diet that I think at least Purina puts out that is supposedly a brain health kind of diet that has higher levels of fats, triglycerides in the diet for individuals that might be somewhat beneficial for the same reasons that the ketogenic diet is thought to help certain humans that suffer from epilepsy. So the idea essentially is by inhibiting metabolism a little bit, slowing down the metabolism of the brain, forcing neurons to shift over to fat metabolism rather than glucose metabolism, you're interrupting in some cases this excessive inappropriate activity that's going on, and certain individuals seem to benefit significantly from that. And there is as I said, I think it's Purina that puts out a diet that potentially could be beneficial for the same reasons. So the last drugs that I'll mention are a couple of other drugs that you're probably familiar with from commercials, advertisements for human pharmacology use, pharmacotherapy. So gabapentin and pregabalin are a couple of drugs that were initially developed as GABA-like analogs, were thought to potentially be useful in the treatment of epilepsy in humans because they look like GABA, and so the idea was they would potentially be of use either at turning up GABA receptor activity or inhibiting the enzyme that breaks down GABA, or by inhibiting the GABA reuptake system transporters at the synapse in the brain. All of those things were potential targets, and so these drugs were just developed decades ago with the idea that they might be anti-epileptic drugs based on some GABAergic mechanism that would be effective then in the treatment of epilepsy. But it turns out that even though these are GABA analogs or GABA-like drugs that have been modified, that it turns out that their specific pharmacology drug target turned out to be probably predominantly their effectiveness as anti-seizure medications seems to be due to their effects on voltage-gated calcium channels. So it's just an example where things unexpectedly turned out. So they created a series of these GABA analog drugs, assuming that they knew what the mechanism of action might be. And when they tested them in animal models, there in fact was anti-seizure activity. But when the pharmacologists eventually drilled down into seeing what the mechanism of action was for these drugs, it turned out that it wasn't primarily due to GABA-A receptor activity, for example, or any of the other mechanisms I mentioned. It turns out that there's an effect, an inhibition on calcium channels, and in particular, even going all the way back to when we talked about cell signaling mechanisms and ion channels in general. You recall I mentioned that there are often auxiliary protein subunits that we're not always sure what they do with voltage-gated channels, potassium channels, sodium channels, calcium channels seem to have these extra accessory proteins that associate with them that modulate the activity of the channel, and we're not always, as I said, certain exactly what they're good for. Well, in this case, these two drugs both seem to target one of these accessory or auxiliary subunit protein components of these calcium channels and have their primary effectiveness then to reduce calcium influx via that mechanism. So sometimes, despite the best of our logic and common sense in pharmacology that we try to apply in drug development, sometimes things are still a surprise in terms of how things turn out. So that'll be all of the drugs then in this slide set that I've underlined are potentially ones that could be the subject of test questions then what they're used for, what their mechanism of action is. There's a fair amount of overlap with what we've already talked about previously with benzodiazepines and barbiturates, so there's not a lot of new information here today, but this gives you a further overview and ideas of just how we might use these neuroactive drugs to interact with and interrupt the occurrence of seizures, and how that's beneficial for the treatment of epilepsy. All right, so that's it for today, and we'll talk about anesthetics tomorrow.